Welcome to Appalachian Wellness for a new tomorrow and a new you. I'm Raymond Oenbrink, the president and owner of Appalachian Wellness, where we specialize in you. Today, we're going to talk about the summarized treatment of the Chronic Inflammatory Response Syndrome. This pyramid illustrates how the treatment of CIRS works. At the base of the pyramid, you see the largest number of people. Most people, especially children, seem to get better when they're removed from the ongoing toxic mold or toxin exposure. A smaller number of people will need to be treated with toxin bindings, such as cholestyramine or Volatile, which is known as Welchol. The next step is to eradicate multi-drug resistant coagulase-negative Staph aureus that forms biofilms in the sinuses. This is generally cultured for at the very first visit, and if this is present, it must be eradicated because it splits MSH to its predecessors and continues the inflammatory process. Anti-gliadin antibodies must be sought and corrected. These are antibodies to the wheat protein, so they will need to be on a gluten-free diet. Many people, especially children, will have transient gliadin sensitivity, and after 90 days of abstinence, no wheat, they will revert back to normal. After 90 days, it's okay, some people will say 1 month, to reinstitute the gluten antibodies, gliadin intake into the diet, and they'll do okay after that, especially once these other steps that precede it have been treated. Men may have low androgen testosterone levels, so we have to normalize those. We have to also correct ADH, antidiuretic hormone, and osmolality, which has to do with the number of salts that are in the bloodstream. Matrix metalloproteinase 9, that's a mouthful, has to be corrected. VEGF, vascular endothelial growth factor. C4A is part of the complement system. Finally, there's transforming growth factor beta 1, which transforms normal cells into basically scar tissue formers or fibroblasts. The final step will be needed by the smallest number of people, and that's use of nasal vasoactive intestinal peptide spray, which works incredibly well, but does not work if we haven't corrected the preceding steps. So I cannot emphasize enough how important it is to correct those earlier steps before starting the VIP. The most essential point of treatment: remove from exposure. If exposure is ongoing, there's no chance of getting better from CIRS. Cholestyramine is given for 30 or more days. If there's any low-level exposure going on, continue the cholestyramine indefinitely as needed to bind the toxins that are being absorbed. Now, these toxins can come in through the air, through your diet. They can, even with a mask on, they can bind to the tear film in your eyeballs and be absorbed. These things can be very, very hard to get rid of. The cholestyramine and Welchol, the way they work, the liver secretes bile into your duodenum, part of your small intestine, when you eat a meal. The gallbladder squirts it out. If you don't have a gallbladder, the liver is continuously dripping a little bit of bile into your gut. That bile contains these toxins. The bile is reabsorbed in the distal part, the last part of the small intestine before it becomes the large intestine. That's called the ileum. Once the bile is reabsorbed, it goes back to the liver. It's recycled and used again. These bile salts, bile-binding resins, grab hold of the bile, so they're excreted in the stool, taking the toxins with them, which is a good thing. Cholestyramine will reduce C3A and C4A elevations. C3A is found where membranes are present, such as Lyme disease or Borrelia, Bartonella, Babesia. C4A is found with any other biotoxins. So we have to get these levels down to know that we're making progress in treating the CIRS. And we will check those at the initial visit, and then we'll check them periodically as we go along. We have to eradicate the biofilm formers. MARCONS is an acronym. It stands for Multiple Antibiotic Resistant Coagulase Negative Staph. The staph actually grows in a biofilm, think of it as a slime, that's within your nasal sinuses. not in the nose itself, but deeper than that in the sinuses. We have to get rid of that if it's in there. It has to be cultured very specifically. A standard nasal culture won't do, where we have to look for an API-staph culture done by a specific lab known as Microbiology DX. The next step is looking for gluten sensitivity. We have to check for anti-gliadin antibodies, AGA. If they're positive, we have to avoid any type of wheat in the diet for at least 30 days. Some people will say 90 days. Then we can re-challenge at that point. If the antibodies become positive again, we'll do a tissue transglutaminase assay, which is a more sensitive test. It will also look at the gluten IgA, IgG, and IgM antibodies. We'll expect to find more of IgG than IgM, but it's good to measure all three. We have to normalize the decreased androgen levels. A look at estradiol testosterone ratios will help determine if the aromatase enzyme is upregulated. We'll get into more of that in the future here. DHE sulfate, DHEA sulfate, stands for dihydroepiandrosterone sulfate. And that's a precursor to all of the steroid hormones. We can give extra DHEA by mouth initially to correct the upstream formation of androgens, but the aromatase inhibitors will continue to swap that androgen into estrogen. Okay, as we get better as far as the CIRS treatment is concerned, that process will cease. ADH stands for antidiuretic hormone. That and osmolality, which stands for the amount of salts in the blood, dissolved in the bloodstream. These two tend to follow each other. A high ADH should be linked with a high osmolality. CIRS causes dysregulation of this, so the ADH may be high with a low osmolality. We have to look for this, and if it's present, we have to correct this, and we have ways we can do this with medications. DDAVP is one of these medications. It's used as a nasal spray, and we'll get into that more in the future. We have to look at the matrix metalloproteinase 9 levels. If those are elevated, we have to fix that. Omega-3 fatty acids are supplemented. We check a leptin level. This has to do with fat storage. If the leptin level is below 7, omega-3 fatty acids work pretty well. 2 grams of basically fish oil twice a day for a total of 4 grams a day does a pretty good job of correcting the MMP9 elevations. If the leptin is above 7, however, we use a medicine called Actos, which is used to treat diabetes. It's a TZD class, and we usually don't use it for as long a term as a diabetic would use it. We just use it for a period of weeks or months to correct the MMP9. And once the MMP9 normalizes, we can discontinue the Actos and monitor the MMP9 levels and make sure they don't rise again. We have to look for the VEGF, vascular endothelial growth factor. VIP is the safest way to increase the VEGF level. VEGF is actually used, that whole concept is used in treating cancer. It causes the formation of new blood vessels. So if we can stop new blood vessels from forming in a tumor, that's a good thing. But it also contributes to the CIRS problem. Chronic fatigue is present because there's not enough oxygen reaching the mitochondria in specific tissues. Brain fog, same situation. The VEGF is low, so we need to get that sucker up there. Vasoactive intestinal peptide works very well. That's the safest way to do that. There are some cautions with it. You have to check a lipase level. That's a pancreatic enzyme, which can go up with use of VIP, so we have to monitor that. So before we start the VIP, we have to check the lipase, the TGF-beta1, C4a, and VEGF initially and then quarterly. And there is a specific protocol that we use when we start treating with lipase. While somebody's taking lipase, we have to check their lipase. While they're taking VIP, we check their lipase levels monthly. Erythropoietin is a more risky treatment. There's more side effects and risk for problems. This is an off-label use of this medication. We have a specific protocol. Again, we check the baseline TGF-B1 because that's really the biggest thing that VIP works on. And the C4a. This time we also check, however, a D-dimer and a CBC. D-dimer can go up with blood clots, such as in the legs or in the blood clots in the lungs. And the CBC, we want to make sure if the hemoglobin goes above 16.5, it's too high. The FDA does not want that hemoglobin above 10 if we're treating somebody with erythropoietin. We have to also ensure that informed consent is signed because this is a risky drug, and it's a good idea to record the lot number of the erythropoietin that's used because there have been recalls in the past. We have to lower elevations of C4A and C3A, avoiding further toxin exposure. Again, that's the very first and foremost thing that we have to do. Erythropoietin will help that. Okay, we have to lower the elevations of TGF-beta1. Losartan, 12.5 milligrams daily. Losartan is a blood pressure medication, so we start with losartan. We give it twice daily. Okay, we can start at 12.5 milligrams and try to increase it to 25, and then maybe all the way up to 50 as the blood pressure will tolerate it. If you get dizzy when you stand up too fast, that's an indication that you're taking too much losartan and we have to back off on the dose a bit. VIP therapy also works very well for this, and it's safer than erythropoietin. And of course, we can consider use of erythropoietin as well. We start the VIP per the protocol. And again, don't kill the golden goose. This stuff works magic when it's used appropriately. There are some guidelines we have to follow. The Environmental Relative Moldiness Index, ERMI, looks at all the different toxic mold that may be present in your environment. And there are some parameters to use. HLA looks at mainly just the mold that are known to cause problems. It doesn't look at all of them, just the ones that are most likely to be causing problems. It's a less expensive test, and it works about as well. We check the MSH level. The MSH level, if it's less than 20,000 and the ERMI is less than or equal to 2 and the HLA is less than 10, it's okay to use the MSH. I'm sorry, the VIP. If the if the MSH is greater than 20,000, we don't want to start the VIP until the ERMI is less than 1, excuse me, and HLA has to also be less than 10. We take 2 puffs in the nose 4 times a day. VIP comes in a little regulated nasal spray bottle. It needs to be kept refrigerated. It's about $200 a month for the treatment. It's fairly expensive, but it does an incredible job. Again, we initially check the lipase, TGF, B1, C4A, VEGF. We also check the blood pressure before we give that initial dose too. We check all these things initially and then quarterly, and of course the monthly lipase levels. This is Dr. Oenbrink of Appalachian Wellness, talking to you today about the Chronic Inflammatory Response Syndrome, also known as CIRS. We're going to give just another brief overview of what this disease process is. This is the basic disease process behind such illnesses as chronic fatigue syndrome, fibromyalgia, Lyme disease, multiple sclerosis has been linked to this as well. 25% of the population at large is genetically susceptible to chronic inflammatory response syndrome, CIRS, as described by Richie Shoemaker, MD. He's a family physician who practiced in Pocomoke, Maryland. He's the individual of genius who elucidated the complex pathophysiology behind CIRS. He has a phrase, genes load the gun, exposure pulls the trigger. These folks with this gene may have worse effects after exposure to a toxic environment, yet given sufficient exposure intensity and duration, anybody can suffer some ill effects. But those that are genetically susceptible are certainly going to be the sickest, and they tend to get sicker quicker on re-exposure. Essentially, anything that causes an inflammatory cytokine storm. Cytokines, you can think of them as like hormones that are very, very short-acting and work only in the immediate area around where they're being released. They're the ones that will bring white blood cells to the source of the infection, for instance. So anything that causes this cytokine storm in a genetically susceptible individual can set the syndrome into motion. As I said before, CIRS is a host response, not a dose response, and those who have subsequent exposure get sicker quicker, secondary to having had a primed immune system after an initial exposure. There is a way to treat CIRS. The Shoemaker protocol is extremely complex with a very steep learning curve. SurvivingMold.com is Dr. Shoemaker's website. It's a treasure chest of information from those who may be afflicted with CIRS. CIRS manifests itself in numerous organ systems. It leads to great suffering. Anybody who's had fibromyalgia, chronic fatigue, etc. can tell you how bad the suffering is. It also causes premature death. Ed McMahon of Publishers Clearinghouse, The Johnny Carson Show, had a water leak in his home. It was fixed, but the water damage was not fixed. Mold broke out in his house, and apparently Johnny should have picked better. I'm sorry, Ed should have picked better parents. He had the gene, and he died prematurely after great suffering from CIRS due to that broken water pipe and the improper remediation that was done. CIRS can also be triggered not only by toxic black mold, but by Lyme disease, Pfiesteria, blue-green algae, cyanophyta, red tide blooms, ciguatera, which is a toxin found in larger tropical reef predator fish. Other exposures even include certain vaccines, such as those to treat Lyme disease and HPV, human papillomavirus, that causes cervical cancer. Our troops that are giving lots of vaccines before being deployed to theater are all given all kinds of different vaccines, and since 25% of them are susceptible, there's a good chance that they're going to have some sort of problems. If it's a vaccine and it's a one-time dose, it might not be as bad as, say, living in a home with mold in it and just being constantly bombarded with the toxins that are going to be present in that environment. For the immune system to function properly, there must be an on switch when you're attacked by some type of a foreign germ or whatever. But for control, there's also got to be an off switch. The population of T lymphocytes that are at the off switch are known as the CD4 plus CD25 plus group. This is a test that uses flow cytometry to detect them. This is the normal off switch, which would engage upon threat resolution or neutralization. Okay, the damage has been done, the infection has been contained. We can go back to just monitoring now and stop fighting. Unfortunately, that switch is broken, and it becomes an autoimmune situation in which your immune system is attacking you. And this is happening all over the body, which is why you get so many myriad complaints and problems. I mentioned that this is a complex disease, and here's a simple overview. Simple, right? So basically, the body acquires biotoxins from either toxin-producing organisms or from food, water, bug bites, what have you. You can see the large blue arrow in the upper right left-hand corner. Normal people, they remove these biotoxins. Okay, the white blood cells come in, the macrophages eat it up, they present the pieces of this thing to other B cells which form antibodies against it, T cells which go around killing it directly. In most folks, these biotoxins are removed from the blood by the liver attached to the immune system. They're broken down, passed through the bile, excreted harmlessly. People don't have any kind of problems, and they live happily ever after. For those who are biotoxin HLA susceptible, however, their surface receptors, the C-type toll receptors, C-type lectin receptors, mannose receptors, and others found in the dendritic cells. These are white blood cells that reach out tentacles like arms and grab the problematic antigens. They release cytokines. These cytokines then get to the hypothalamus where they can cause damage to the MSH, VIP receptors, and others. Leptin receptors are also damaged. This causes the fat cells to produce more leptin, which leads to obesity. We've all heard people who are overweight. No, it's not that I'm not eating much. And indeed, you look at them, they're not eating much. They're exercising, and they're still very obese. Well, leptin is usually a culprit there. This cytokine storm also gets to the capillaries in the upper right-hand corner. These capillaries attract white blood cells, leading to restricted blood flow, lower oxygen delivery to the tissues. Okay, this stimulates normally VEGF, which would say, let's build more blood vessels so we can get more oxygen to these blood cells. TGF would also be present, which can change, transforming growth factor beta-1 changes the types of tissue cells, often into scar tissue. Now you've got, however, with this attack, you've got more TGF beta-1, you've got VEGF is actually decreasing. It's not rising the way it should rise. You get fatigue, muscle cramps, short of breath, erythropoietin, VIP can help this. The TGF changes the cell types. It especially hits liver, lung, and skin. So you may see changes on somebody's skin when you look at them. They may have like flaky, like an eczema type thing going on. Immune system symptoms. They could develop inappropriate immunity, such as antibodies to gliadin, which is the wheat protein. If you eat wheat, then you get lots of muscle aches, pain, fatigue gets worse. The immune system can also be affected. Cardiolipins may form, which cause abnormal blood clotting, can cause miscarriages in women who are pregnant, that sort of thing. T regulator cells that shut off the immune system can become pathogenic or disease-causing. They don't work right. C3A is a complement product that's found where there are bacterial membranes. Think of Lyme disease. C4A is just from toxins in general, and it's associated with low blood perfusion through the capillaries, which means low oxygen delivery. High levels of cytokines produce flu-like symptoms, headaches, muscle aches, fatigue, unstable temperature, difficulty concentrating, and more. Excuse me. High levels of cytokines are associated with increased levels of other immune response-related substances, including TGF-beta1, matrix metalloproteinase 9, interleukin 1b, platelet plasminogen activating inhibitor factor 1, MMP9 develops inflammatory elements from the blood to the brain. It gets across the blood-brain barrier. So it hits brain, tissue, nerves, muscles, lungs, joints. It combines with PAI1, increasing clot formation, which causes further arterial blockage. Coag-negative staph, MARCONS, forms in the nose. Okay, this also splits MSH, dropping the MSH levels, okay, which further exacerbates the inflammatory cascade and makes it worse. With low levels of MSH, the pituitary starts making less ADH hormone, antidiuretic hormone, leading to thirst and frequent urination and susceptibility to electrical shocks from static electricity. It seems to cause salt buildup on the skin. Reduced androgens, testosterone, can happen with men. Okay, all of a sudden they're losing muscle mass, they have fatigue, they're not feeling themselves, the libido just goes to pot. They're not very manly anymore. Changes in cortisol and ACTH levels. Again, you get dysregulation, which means normally ACTH goes up, causes the cortisol to go up. Just like with the ADH, when the osmolality goes up, the ADH should go up, but they become dysregulated. They don't respond the way they're supposed to. This has all happened at the pituitary level within the brain as a result of the damage that these cytokines are doing. Patients should avoid steroid supplements such as prednisone whenever they can, because this will also interfere with the problem. You'll get prolonged illnesses going on. The white blood cells lose their regulation of cytokine response, so that recovery from other illnesses, infections, etc. can be slowed. The other gastrointestinal problems, you can get leaky gut, malabsorption in the gut, resulting diarrhea. The leaky gut lets proteins and things across the gut barrier, which can then cause further inflammation. You think of the gliadin sensitivity. That can also happen with not just wheat protein, but lots of other proteins, and there are tests that can be done looking for that. With the low levels of MSH, you also get chronic pain, okay? You don't get very good sleep. You get non-restorative, non-restful sleep, okay? All of this is due to damage to the MSH system in the pituitary and the hypothalamus, and all these different things, according to this diagram, as you can see, are all caused directly due to the reduced MSH. So if we can figure out how to get that MSH up, a lot of these other things will improve. The key to getting the MSH up, however, involves treating all the different things that caused it. So again, this is a very complicated disease. Very few doctors want to go to the trouble of learning about all of this. It's brand new, revolutionary at this point, as I'm recording this slide in 2017. But I think it's going to take a long time for the general medical community to catch on, even though there's lots of good peer-reviewed journal articles on this. It's just such a steep learning curve, and it's very, very intensive medicine. It takes a long time to see these patients. Insurance doesn't properly reimburse for the amount of time that the physician is taking with these folks. It's a death sentence for the people that have it. It will cause great suffering, and it will shorten lifespans. So there is a way to reverse every step on the CIRS protocol and reverse the progression of this disease, restoring health. But it requires very careful attention. It's very lab-intensive medicine. These are usually very needy patients who have been told for years, oh, it's all in your head, we don't see anything wrong. Well, the reason they don't see anything wrong is they're not doing the right tests. Some of the testing here is very, very esoteric academic testing. The good news is you're sick, we can find it, we can fix it. Yeah, it's in your head, but it's also in a lot of other places in your body as well, and that doesn't mean we should ignore it. You need help, we can provide that help. Let us help you. Appalachian Wellness for a new tomorrow and a new you. I'm Raymond Oenbrink, President and owner of Appalachian Wellness. Today we're going to talk about the approach to the patient who suffers from Chronic Inflammatory Response Syndrome, or CIRS. The protocol developed by Dr. Shoemaker takes on a very methodical, stepwise approach to treating CIRS. The absolute most crucial step is complete avoidance of exposure in the future. The afflicted become sicker quicker because their immune system has already been primed. This makes evolutionary sense. When triggered with a threat to our lives, our immune system, our stormtroopers, our first responders against infection, need to be ready to go in an instant with a hefty armament to take out specific attackers, be they strep, staph, viruses, anything that we've been exposed to in our past, etc. These first responders also have good memory of things that they've met in the past and know how to defeat. It's important to remember, too, that if the patient suddenly seems to relapse and worsen, the only logical approach is to assume re-exposure. We may not know what, when, where until we look, and go back to the basics, back to square one at the initial step, and resume the sequential treatment that Dr. Shoemaker designed. VCS testing, visual contrast sensitivity, is very specific for CIRS. It can serve as an early warning system for re-exposure. Once the exposure has been removed, often the most difficult step, the toxins need to be removed and then they require monitoring. This cannot be overemphasized. You will not get better if there are still toxins in your environment. Briefly, the steps will be listed below and we will follow up with more detail on other shows. Number 1, after exposure reduction or removal, cholestyramine, Questran, or Cholcelivam, Welchol bind the toxins. Welchol has about 20% of the effectiveness that Questran has. C3A, as part of the cascade of the complement system, rises with presence of pathogenic membranes. Think of things like Lyme disease. C4A rises with other non-membrane biotoxins, volatile organic compounds, VOCs. Mold is a good producer of VOCs. Sigma-toxin comes from consuming tropical reef predator fish, larger fish, dinoflagellates like red tide bloom, that sort of thing. Patients need to be educated about the risks posed by volatile organic compounds, VOCs. We'll get more into this later. Multiple antibiotic-resistant coagulase-negative staph. That's a mouthful. We'll just call it MARCONS from now on. It needs to be looked for and cleared. There's an APA staph test done by Microbiology DX. It takes time. This germ causes a biofilm. It's a slime layer, if you will, in the sinuses. It's not a planktonic or free-living form of bacteria. These staph take time to culture, and it's best to get this culture to patient's initial visit. It can take 4 weeks or more before we have the results back. Gluten gliadin sensitivity, wheat protein sensitivity, needs to be looked for, especially in younger patients. They seem to be more prone to this. If the AGA is positive, a 1 to 3 month trial of a strict gluten-free diet, it may improve their condition. If they relapse on reintroduction to gluten, tissue transglutaminase testing and other further avoidance may be necessary. Androgen and aromatase function, if impaired, often responds to upstream DHEA supplementation. Aromatase is an enzyme that breaks down testosterone into estradiol, which is one of the estrogens, also known as E2. And with the CIRS disease process, the aromatase enzyme seems to go into overdrive. Increasing dihydroepiandrosterone, or DHEA, will help with those androgen levels, but the really definitive treatment involves treating CIRS. Once the CIRS is under control, the excess aromatase activity resolves. Things get back to normal. Middle steps of the protocol involve matrix metalloproteinase 9, antidiuretic hormone and osmolality dysregulation, adrenal corticotropic hormone cortisol dysregulation. All these may be affected, and we need to look. When I use the term dysregulation, ADH usually goes up as the osmolality or number of salts in the blood go up. ACTH causes the cortisol to go up. With these folks, instead of rising in parallel, one may be going up while the other one may be going down, and this is another indication that CIRS is going on, and we need to address these issues. And these issues will correct as we get the CIRS under control. C3a, C4, and leptin levels will influence our approach to correcting all of these abnormal markers. Monitoring all these parameters during treatment is indicated based on the overall patient condition and as indicated by the VCS early warning system. And again, it's back to square one if the patient gets worse. The pinnacle of treatment involves correction of high transforming growth factor beta 1 using low levels of vasoactive intestinal peptide, which is replaced with the nasal spray. There's a diagram that shows how people will improve. We've reviewed that on a prior slide. This is referring to that pyramid-shaped diagram. Appalachian Wellness. For a new tomorrow and a new you. Our specialty is you. I'm Raymond Oenbrink, president and owner of Appalachian Wellness. And we're going to talk today about the genetic susceptibility to CIRS, Chronic Inflammatory Response Syndrome. Don't be scared off by some of these words, because I will define them as we go along. Human leukocyte antigen, it's abbreviated as HLA. Haplotype just basically means a genetic trait. Think of blue eyes versus brown eyes. Those are just different haplotypes. So these words may be new to you, but they're really nothing to fear, and it's pretty easy to wrap your head around them if you pay attention. Unfortunately, the CD4-CD25 off switch of the immune system does not always engage, especially in those with susceptible haplotypes, based on the HLA antigens HLA DR1, DQ, DR3, DR4, and DR5. The test is very difficult and complicated to interpret. However, Dr. Shoemaker has created what he calls the Rosetta Stone document that assists the practitioners to figure out what's going on with these complex genetic results. And he's even linked specific haplotypes to specific sensitivities. You know, one person may be more sensitive to mold, another may be more sensitive to Lyme disease toxins. When HLA susceptible individuals are triggered, the off switch does not properly engage and autoimmunity develops, similar to but different from lupus and rheumatoid arthritis. And when I say similar to but different from, the standard blood markers that would be found in lupus and rheumatoid arthritis are not affected, but there are different, very, very esoteric, not widely known blood markers that can be tested that will show abnormalities. So when you've gone to other doctors in the past, they can't find anything wrong. The reason they can't find anything wrong is they're not looking at the right things. They're not looking at the right blood tests, and that's why they're getting into trouble. Unfortunately, though, the immune system starts attacking your own cells all over the body. Joint damage, nerve damage, muscle damage, heart and lung damage, brain damage, vascular damage, your blood vessels, impaired mitochondrial oxygen supply. The mitochondria are the power plants located in each cell. They take something called NAD and form NADH from it, and then that's used to form ADP into ATP, which is the energy currency of the cell. Think of petrodollars if you'd like. This is all happening due to regional microscopic circulation at the capillary level where not enough oxygen is getting to the mitochondria. We all learned in school that cells burn sugar, glucose, and produce carbon dioxide and water. Well, this is all part of the burning or oxidation process that goes on. At each step in the oxidation process, which involves things like the glycolysis Hebden-Meyerhof cycle, if there's not enough oxygen, it's not a very efficient system, or ideally the Krebs tricyclic citric acid cycle, the TCA, is a much more efficient way, but that requires oxygen to be present to get the energy. And that's why these people have so many aches and pains and brain fog and low stamina and everything else. They were just miserable folks they've got a serious disease when they've been exposed. It'll shorten their life as well as causing great suffering, and we can reverse every step of the process with Dr. Shoemaker's protocol. He's truly a genius, what he came up with. This is Dr. Oenbrink from Appalachian Wellness, where our specialty is you, and we'd like to give you a new tomorrow and a new you. Today we're going to talk about visual contrast sensitivity testing, the VCS test, which is great for not only diagnosing, it's a very sensitive and specific test for CIRS, Chronic Inflammatory Response Syndrome, but it's also used as we go through the treatment regimen to monitor and quantitate the progress that's being made against this disease. The U.S. military developed a visual contrast sensitivity test, VCS test, that evaluates the function of the rod cells in the retina. The retina is the back of the eyeball. Think of the film in the camera. The rod cells are black and white receptors. They don't see color like the cones do. They only see black and white, but they're also exquisitely sensitive markers. These are the canaries in the coal mine when it comes to low oxygen delivery and poor microcirculation within the retina. This capillary level dysfunction is a key part of CIRS and can be quickly and easily checked and monitored, which is very important to routinely monitor with this simple vision test. Those afflicted with CIRS have inflammation and impaired circulation at the capillary level, causing inadequate delivery of oxygen to the mitochondria, the power plants of the cell at that level. Diffusely, this is happening all over the body, every tissue involved. So if the abnormal VCS is noted, you can bet that there's poor delivery system, not just in the retina, but all over the body. The test can not only be used in part diagnostically for CIRS, but again, it's a good prognosticator. It tells us how we're doing and what the future is going to look like as we keep doing what we're doing to manage, treat, and hopefully improve CIRS with our therapeutic endeavors. And there's some references here if you want to look further. These VCS testing is very reproducible marker. I mean, it's accurate. You know, you can test it now and test it later, and test it twice. Well, boom, boom, right in a row, and you're going to get very similar results. Okay, they're more reproducible in their presence as a quantitative, means not just the yes or no, but exactly how much yes or no level for those with the syndrome. Thanks to the efforts of Dr. Shoemaker, even the timing and sequence, the sequential activation of innate immune elements, he's been able to look at the VCS test and specific laboratory markers over time. If somebody is exposed to a bad environment, over the first day, these are the markers that will change. On the second day, the following markers will change. And on the third day, these other markers will change. He's done a remarkable job of putting together the exact picture of what's going on in the body, and the VCS is a big part of it. These lab markers that I mentioned include things like reductions of the alpha melanocyte stimulating hormone, MSH, that happens in the hypothalamus at the base of the brain and the pituitary. That's sort of the link between the brain and the endocrine or hormone system. Vascular endothelial growth factor, VEGF, is a compound that the body produces when there's low oxygen levels. This is the thing that causes more tunnels to be made, more capillaries to be put out there so that more oxygen can get to the oxygen-starved tissues. It's also used as a cancer treatment. If we can impair VEGF so we're not getting as many new blood vessels growing within tumors, we can starve tumors of their oxygen. Dysregulation. Typically, for instance, as the osmolality goes up, the ADH, antidiuretic hormone, will go up. Osmolality has to do with the amount of salts in your bloodstream. So if you're getting your blood too concentrated with too much salts, you would want the antidiuretic hormone, which causes water retention, to also rise and dilute those salts back out to the normal level. Dysregulation means that one may be going up while the other one is going down. Not a good thing. Same thing with adrenocorticotropic hormone. Usually when that goes up, the cortisol follows. Again, you get dysregulation of these and of other markers. You can get elevations in C3A, C4A. These are part of the complement system within the immune system. Transforming growth factor beta 1 tends to cause like scar tissue formation, basically, especially the lungs, the liver, and the skin. Matrix metalloproteinase 9 works to sort of cleave through tissues and allows infections to spread. Okay, so it kind of breaks down the walls in different tissues, allowing inflammation to spread throughout tissues, and those levels will go up, which is not a good thing. Leptin goes up because of damage to the leptin receptors at the hypothalamus and pituitary. Leptin is involved in regulating fat storage. So people who swear they don't eat hardly anything at all, and yet they keep gaining weight, well, you watch them, they're not eating much. They do exercise, and they're fat, and they keep gaining weight. Well, the problem there is quite likely going to be dysregulation of their leptin system. And as we treat the CIRS, the leptin levels will come down, and then the weight loss begins. And there's references for all of this as well. Appalachian Wellness, for a new tomorrow and a new you. Our specialty is you. I'm Raymond Oenbrink. I'm the president and owner of Appalachian Wellness. And today we're going to talk about Chronic Inflammatory Response Syndrome, CIRS, and volatile organic compounds, the dangers that these cause. These are the ultimate ninja. Once CIRS is established, things as seemingly innocuous as volatile organic compounds, VOCs are frequently but not always produced by pathogenic species, disease-causing species like mold and conditions. They trigger flares of the CIRS process with worsening of your symptoms, worsening of your VCS, visual contrast sensitivity, and worsening of your lab markers, your blood markers. An important concept to note is these VOCs can be subliminal, and they don't always have to be caused by fungi or other things of this nature. Subliminal means below the ability of the senses to detect. You may not be able to smell it, but that doesn't mean it's not there and not making you worse. And yet it can still cause the inflammatory cascade and amplification common with CIRS by way of the complements as part of the immune system. A patient living near a power plant burning coal produces various sulfoxides. Some of these can be triggered. Subtle changes in meteorologic conditions, maybe the wind shifts and some of that sulfoxide plume is being blown your way. Being exposed to plasticizers, common in new cars, buildings, carpeting, etc., that have not yet finished outgassing their VOCs. They may also serve as triggers. And again, they may not be at a level that you can smell, but if you feel like you're just getting worse when you go in a certain building, that's the ninja at work. These VOCs are very small molecular weight entities. They're tiny chemicals that are not triggering a classic antibody-mediated immune reaction, including the IgE or allergic reaction, but they are engaging the complement cascade of the immune system, which we'll talk more about in a bit, with its inherent amplification, read severely symptomatic on an immediate basis without any prior warning by a subliminal, below the threshold of detection, exposure. You don't smell it, you don't know it's even there until you're getting sick. Again, you can't smell it, discern its presence, know it's there, but boy, if you suddenly feel yourself getting worse, it's not all in your head. This assassin, by the way, is targeting you and you alone. Other people will sit there and be absolutely fine, not have any symptoms at all. Remember, CIRS affects about 25% of the population. And when you have CIRS, my wife and I both have it, and there are certain places that she'll be triggered and I won't have a problem. We'll go somewhere else, I'll be triggered and she won't have a problem. This is a tailor-made ninja. He's only after you. And again, nobody else can discern it. Everybody else, including your doctors, think you're crazy. But you know better. And we in modern medicine who have studied so long and hard don't understand this. We think of these neurotic, needy people as being crazy, but they're not. Crocs get sick too is an adage I was taught way back in residency, and it's an adage to stick to. Just because you don't understand doesn't mean it's not going on. And unfortunately, physicians tend to react to ignorance with arrogance. I'm a physician. If I don't know it, it can't be important. These poor folks are suffering. They've been kicked around. They needed to be treated with compassionate understanding and respect, which is what you will find at Appalachian Wellness, because we understand. The absolute initial and most important step in dealing with biotoxin illness, CIRS, is identification of and isolation from the source of the toxin exposure. Identification does not necessarily mean specifically what species of mold or molecule in the VOC system triggers you. It just needs to know kind of what's going on, what areas you can't go to. We know of certain molds that are triggers. Okay, and even if we can't necessarily find the specific mold and we know that certain biotoxins are going on, this has caused great controversy in the legal system. And unfortunately, a lot of very sick people exposed to mold have been left hanging without any type of recourse. It just simply means knowing what, where, when to avoid. If there are riverbeds that dry up during the summer or during the winter and you start getting sick at about that time, there may be some Pfiesteria, Cyanophyta, something going on in that riverbed that's now drying up. Molds and these microorganisms release these toxins when they're under stress. Don't use bleach on mold because it can cause VOC release as well. White vinegar works better than bleach when you're trying to clean this stuff up. Unfortunately, this is also, this elimination is the most expensive and difficult step. Somebody who's been ill, perhaps unable to work, has exhausted their financial resources from going from doctor to doctor, now must choose between leaving their home, place of work, place of worship, place of education, etc. And a lot of schools are affected with damp building syndrome for an undetermined period with possible extensive and expensive remediation that's being taken that you're on the hook for, because most insurance companies have written riders into their policies at this point that they're not going to be liable for mold-related illness or for fixing the problem of a moldy home. They say that's not our problem, and it's a crime in my opinion. Remember, you will not improve without getting rid of the source of exposure. This disease will make you suffer tremendously as it shortens your life. The final outcome after great suffering will be a premature and painful demise. This may seem dramatic. It cannot be overstated. It's simply the truth. Medical schools frequently teach that the best clinicians are those who obtain the most thorough, detailed, and focused history. We're taught that the patient will tell you what's wrong if you listen to them properly. The trick lies in teasing out the essential, valuable information. And we at Appalachian Wellness thank you for taking the time to very carefully complete your pre-visit questionnaires as accurately and completely as possible before each visit. Treating CIRS, things change between visits, and I want to be able to pick them up before you get worse. I know these questionnaires, these forms that I have online are very, very detailed. I designed them myself. I've filled them out myself. It takes a long time. Please don't put handcuffs and a blindfold on us and ask us to help you. You have to cooperate and do your part. We use this information. We track this information carefully, and we're hoping to be able to use the information you provide us today to help others in the future as we do look-back research on our results so we can help you and others better in the future. Appalachian Wellness, for a new tomorrow and a new you. I'm Raymond Oenbrink, President and owner of Appalachian Wellness in Asheville. We're going to talk about Chronic Inflammatory Response Syndrome, CIRS, fungal testing, and how it's done, specifically the Environmental Relative Moldiness Index, which is a test called ERMI, and the health effects roster of type-specific formers of mycotoxins and inflammagen, second version, also known as HERTSMI-2. Perhaps you can understand why we in medicine like to use acronyms wherever we can. It's a mouthful. The most important step of CIRS therapy is identification of and removal, avoidance of any re-exposure. This cannot be overemphasized. Very, very important concept, because if you don't do this, you're not going to get better. Micrometrics is a lab company that provides extensive testing via what's called DNA amplification of environmental samples. Basically, they take house dust and they run it through an amplifier system, essentially, that identifies the DNA in that house dust and comes up with what the problems are. The ERMI looks at 36 species divided into 26 specific species clusters associated with water-damaged buildings, Group 1, and then 10 common species clusters not associated with water-damaged building called Group 2. The number calculated as the ERMI is actually the sum of the logs of the concentrations of the DNA of the different species. The mold index is the difference between Groups 1 and Groups 2. And there's the website for Mycometrics and some articles on how they designed that test. The safe level of ERMI will depend on other factors such as the patient's C4a and alpha melanocyte stimulating hormone as noted below. The important thing is you have to keep the ERMI to a certain level depending on what the C4a is. A thorough and careful history may reveal clues to other exposure risks from dinoflagellates, either aquatic, freshwater, or marine saltwater, ciguatoxin from consumption of tropical reef predator fish, the larger fish, Lyme disease, Lyme vaccine, or other vaccine exposure, such as HPV for cervical cancer prevention, the human papillomavirus. If a one-time vaccine triggered the cytokine storm preceding the onset of CIRS, the patient could be counseled to avoid repeat of that vaccine or other exposure future vaccines that may cause cytokine storms to avoid future problems. More information is available. Appalachian Wellness. For a new tomorrow and a new you. Our specialty is you. I'm Raymond Oenbrink, the president and owner of Appalachian Wellness. We're going to talk today about Chronic Inflammatory Response Syndrome and toxin binding using cholestyramine, abbreviated as CSM, also known as Questran, or colsevalam, also known as Welchol. Cholestyramine is an anionic binding agent that's taken by mouth. It disrupts enterohepatic circulation by absorbing bile, preventing its reabsorption in the ileum and hepatobiliary recycling. Boy, that's a mouthful. Basically, what this stuff does is you take it about 30 minutes before a meal, chase it with a fairly large glass of water to get it out of your stomach and into the first part of your small intestine, the duodenum. That's where the stuff works. If you have a gallbladder, during a meal, your gallbladder basically contains bile, which is a detergent that's designed to emulsify or break up fats in your meal so they can be absorbed easily. Bile contains toxins that came from the volatile organic compounds and other things that you've been exposed to as you've become afflicted with CIRS. And the bile normally will go into the upper part of the small intestine, the first part of the small intestine, the duodenum, and then get reabsorbed in the last part of the small intestine, which is called the ileum, and the portal vein will take it back to the liver for recycling. That's normally what happens if you have a gallbladder. If you don't have a gallbladder, you're constantly dripping bile into your gut, okay, to absorb whatever fats may be present. When you take the cholestyramine, this stuff binds the toxins and the bile so it does not get reabsorbed and make its way back to the liver, and it's excreted from the body in the stool. So it's a very good thing to have this stuff. These toxins are, again, excreted by the liver into the bile system, the biliary system, which then dumps it into the duodenum, the first part of the small intestine, and gets reabsorbed and recycled from the ileum, the distal last part of the small intestine, so it can go back to the liver and repeat the process. And these medications basically bind the bile and the toxins, helping the body to excrete them in the stool. These medicines are somewhat constipating, okay? This can be improved using osmotic laxatives such as polyethylene glycol, also known as Miralax, sorbitol, and magnesium. Cholestyramine is taken as a 4-gram packet about 30 minutes before meals and at bedtime. It actually contains 4 grams of anhydrous cholestyramine, pure cholestyramine without water, and another 9 grams of cholestyramine that may have some water within it. It's a dry orange powder. It's got a bit of an orange flavor to it. It also got sucrose or table sugar in it because it's not a really good tasting stuff. If you choose to use the colsevalam, the Welchol only has about 20% of the effectiveness at binding these things as cholestyramine. So in theory, it'll take 5 times longer to get the same effect. So if it's possible for you to tolerate cholestyramine and you want to get better faster, which is what I'd certainly recommend in a terminal illness that's trying hard to shorten your life and causes a lot of suffering, it's a personal choice. Do the best you can. Some people will alternate. Take a dose of cholestyramine, follow it with a dose of Welchol at the next meal, then cholestyramine, then Welchol at bedtime. And that's perfectly fine too. It's an individual choice. Medication should not be taken 2 hours before or after each dose of the cholestyramine, as it can interfere with air absorption as well. Cholestyramine aids in the excretion of biotoxins from the body, thus reducing the overall toxic load that's triggering the immune system's complement system and the cytokine activation pathways that the ineffective T regulatory cells are unable to rein in and bring back under control. The broken off switch, if you will. This will help to reduce the C4A and the C3A. And there's some references to that information as far as these drugs are concerned. Not everybody, again, will tolerate the cholestyramine. It can be difficult to take properly. The alternative would be the Welchol, 1,875 milligrams twice a day with meals, which absorbs about 20% of what the cholestyramine is able to absorb. And again, we can alternate one and then the other. C3A can also be reduced by high doses of statins, such as simvastatin, 80 milligrams a day. This is a cholesterol-lowering medication. These drugs tend to reduce the body's resource ubiquinol CoQ10, which is essential for metabolism. It's basically how the cells in the body, the mitochondria in the cells, burn fuel and oxygen to get water and carbon dioxide and energy. So it's a good idea to take at least 150 milligrams of CoQ10 if you're going to be taking a statin. And recall as a practitioner that medicine is an art. If somebody's had a prior difficulty taking statins and they want no part of going on it again, you've got to respect the patient's right. Statins can cause severe muscle damage, so if somebody's had a problem with that in the past, I can certainly understand their reluctance to go on a statin in the future. C3A will also decline with our other interventions, though. So if you have an elevated C3A level, statins are not the only choice that we have. We do have other options to bring that down. And there's a bunch of references available here too. Appalachian Wellness, for a new tomorrow and a new you. I'm Raymond Oenbrink, the president and owner of Appalachian Wellness. And we're going to talk today about Chronic Inflammatory Response Syndrome and Multiple Antibiotic-Resistant Coagulase-Negative Staph, also known as MARCONS. Low levels of MSH can reflect multiple antibiotic-resistant coag-negative staph, MARCONS, living in biofilms. This is not the free-living planktonic form of bacteria, but biofilm is like a slime layer within the sinus cavity that protects the organism so that the antibodies can't get to it. Think of trying to slog your way through deep mud. That's essentially what our white blood cells are trying to do, getting through this slime layer, looking for where these germs that are producing the slime as a defense may be hiding. So the MARCONS is basically safely ensconced, living in a nice, safe, secure area that also is not very well penetrated by antibiotics. It's a very slow-growing microbe that must be differentially cultured using the API staph technique. This is not a simple routine lab test and is only done by Microbiology DX, the lab recommended by Dr. Shoemaker for this test. Collecting the sample is a little uncomfortable. A swab has to be put in the nose, similar to what's done for a flu test, if anybody's ever had that done before, but it does have to go deeper than what the flu test is. So it's a little uncomfortable. It just takes a few moments, though, and it's over. It's really nothing to worry about. Once the test is done, we give you the specimen and ask you to mail it into the lab with the payment for the test. MARCONS is best treated with a proprietary BEG nasal spray. It contains Bactroban, which is known as mupirocin. Ethylene diamine tetraacetic acid, EDTA, is essentially a detergent that breaks through the slime layer so the antibiotic can get to the slime and fix it. Gentamicin is the antibiotic in the medication, the spray. And we also give by mouth rifampin, 300 milligrams 2 caps daily for 1 month. So we're hitting it with three different antibiotics and a detergent to break through the slime. And that seems to be a very effective technique. And this medication was developed by Hopkinton Drugs in Hopkinton, Massachusetts. And again, the biofilm alters the sensitivity of the staph to eradication because it's a very good camouflage and barrier to antibiotics and other white blood cells, everything else. And Hopkinton Drugs is the one that you get the spray from. The EDTA breaks down the biofilm, allowing the antibiotics to get access to the bacteria. As MARCONS is eliminated, the MSH will begin to rise back toward normal. And if you recall the big slide we presented earlier that had all the different things that go wrong in the body in CIRS, MSH was like the central figure to that slide. As we fix the MSH problem, everything else starts to self-correct. Appalachian Wellness, for a new tomorrow and a new you. I'm Raymond Oenbrink, President and owner of Appalachian Wellness. We're going to talk today about CIRS, Chronic Inflammatory Response Syndrome, and gliadin or gluten sensitivity, also known as celiac disease. Since CIRS induces and causes autoimmunity with the immune system reacting against self, gliadin, a protein found in different grains, gliadin sensitivity evolves in about half of children and about a third of adults with CIRS. IgA and IgG anti-gliadin antibodies need to be looked for and ruled out with lab testing. It's a blood test. If present, the initial step involves anywhere from 1 to 3 months of a gluten-free diet, no wheat products. Okay, you can get more information about that online, and on our website we have links to that. If testing that remains positive for these antibodies, there's a more specific test we can do. It's a little bit more expensive, called a tissue transglutaminase enzyme test, and we could do that after a period of abstinence from gliadin. If the patient starts getting worse again, then we would do that next test. Positive results of that next test usually require a lifetime avoidance of wheat proteins, but that's usually the exception, not the rule. And again, here are some resources for the gluten gliadin diet restrictions, and you can click on these links online. All this information in the slideshow and video is also present in an article that I wrote, and you can just click on the links there and get the information. If GI symptoms return after the period of gluten abstinence, it may be worth the lifelong avoidance of gluten. And these are not going to just be GI symptoms too. This is going to worsen the CIRS completely, so it'll affect basically every organ system. You don't want to screw around with this. This is where you have to really have a sit down with the patient and discuss the options and what the ramifications are if they continue to choose to use wheat in their diet despite their sensitivity. They're not going to really get completely better with the CIRS. Appalachian Wellness, for a new tomorrow and a new you. I'm Raymond Oenbrink, the president and owner of Appalachian Wellness here in Asheville. You can follow us on social media. Today we're going to talk about CIRS and how it affects aromatase and causes androgen testosterone deficiency in men. Androgen testosterone deficiency is another common dysregulation that occurs in CIRS. The aromatase enzyme can be found in many tissues, including the gonads, so the granulosa cells there, the brain, fat tissue, placenta, blood vessels, skin, bone, as well as the tissues of endometriosis, fibroids, breast cancer, and endometrial cancer in women. There are 3 estrogens: estrone, E1, estradiol, E2, and estriol is E3. These estrogens all vary in different ratios among different species of mammals. In female human beings, adults, the estradiol is about 85%, estrone is about 14%, and estriol is about 1%. Estriol is the one that's most strongly linked with breast cancer. Aromatase is an enzyme that converts testosterone to estrogen. The testosterone ratio elevation is an indication that aromatase is overactive. The normal ratio for adult males is about 1 in 200. There are 3 ways to increase testosterone levels: give additional testosterone, use an aromatase inhibitor, which is not recommended, and supplement with dihydroepiandrosterone sulfate, otherwise known as DHEA, about 20 milligrams a day. This is an upstream, if you will, precursor for all of the different sex steroids. And of course, as you treat CIRS, the problem of the aromatase excess activity will resolve all by itself just with the treatment for the CIRS. The physiologic derangements of CIRS that cause the problem will correct, again, as we fix the underlying CIRS problem. Appalachian Wellness for a new tomorrow and a new you. I'm Raymond Oenbrink, President and owner of Appalachian Wellness here in Asheville. Today we're going to talk about CIRS, correcting the antidiuretic hormone, ADH, and osmolality dysregulation. ADH osmolality dysregulation occurs with CIRS. What does this mean? Normally, the physiologic response to dehydration, which is common in CIRS, would be that the osmolality increases. Too much salt, not enough water in the bloodstream. And as that happens, ADH, antidiuretic hormone, causes the kidneys to resorb more water to try to dilute the excess salt in the blood. So if the ADH is high, the osmolality should also be high. As the osmolality drops, the ADH should also drop. They could run in the same direction under normal circumstances. This doesn't happen with CIRS, however. CIRS will break this pattern. A careful history may elicit static-like electrical shocks, often with salt accumulation on the skin, thirst, frequent urination, and claw-like cramping of the hands, with severe muscle cramps in other areas as well. It can also aggravate restless leg syndrome. CIRS patients are prone to dehydration. The normal physiologic responses to dehydration begin with individual cells giving up some of their water to the extracellular space, both extravascular outside the blood vessels and intravascular within the blood vessels. Orthostasis may develop with prolonged dehydration. This can be picked up historically or documented by getting a standing and supine pulse and blood pressure measurement. Orthostasis basically is a sign that there's not enough fluid in the pipes. Okay, your blood vessels are not full. So if you go from a sitting or standing position, sitting or laying down position, and you suddenly stand up, you get dizzy and woozy and almost fall over, maybe you do faint, because there's not enough blood getting up to your brain. You're relatively depleted intravascularly. There's just not enough fluid to get up to the brain, and you briefly lose consciousness. So you faint, you fall to the ground, hope you didn't hurt yourself, and once you're down on the ground, you've got essentially a level playing field, and fluids tend to go to the same level space. Now all of a sudden your brain is getting oxygen and blood again, so you wake up and wonder what just happened to you. Vasopressin arginine, also known as desmopressin or DDAVP, is a medication that can be used 0.1 milligrams per night to 0.2 milligrams every other day, or at the very most 0.1 milligram twice daily can be very helpful. Basically, this is a nasal spray that helps to correct the ADH issue. It causes fluid retention. It's good to monitor daily weights and weekly electrolyte, especially low sodium and potassium elevations, as this can happen with these medications. DDAVP can also be used to correct acquired von Willebrand syndrome, which is develops in some CIRS patients, and that's noted with easy bleeding and bruising. So if easy bleeding, bruising, heavy periods occur, it's a good idea to run the von Willebrand profile and see if that's what's going on, and if so, maybe short-term use of some DDAVP as we correct the CIRS process, and as the CIRS process corrects, the von Willebrands will also correct. Adrenocorticotropic hormone, adrenal dysregulation can also occur. ACTH causes the adrenal glands to produce more cortisol. And again, dysregulation will occur. Usually with ACTH increases, cortisol increases, and we'll get more into that in the future. Typically, this will all correct nicely once VIP, if necessary, and other abnormalities of CIRS are corrected. And there are some references available to this. Appalachian Wellness for a new tomorrow and a new you. I'm Raymond Oenbrink, President and CEO of Appalachian Wellness here in Asheville. Today we're going to talk about Chronic Inflammatory Response Syndrome, CIRS, and how a low amylose diet and specific medications can lower your levels of elevated matrix metalloproteinase 9, tumor necrosis factor, plasminogen activator inhibitor 1, and leptin. CIRS also causes elevations of MMP9, TNF, PAI1, and leptin. These elevations are best dealt with in two ways. First, an absolute necessity is a low amylose diet. Amylose is a high glycemic index sugar that can be quickly utilized. It's found in seeds and roots, except for onion and garlic. This means the elimination of grains such as wheat, oats, rice, barley, and rye. The chart shows different seeds that have amylase inhibitors within them. These are okay to eat. Amaranth, quinoa, buckwheat, sorghum, and corn are all okay to eat. Second, medication or supplementation of omega-3 fatty acids is used. If the leptin is less than 2 grams of omega-3 fatty acids taken twice daily for a total of 4 grams a day will help lower the CIRS mediators. If the leptin is above 7, Welchol is a TZD class drug used to treat diabetes. This is preferred for patients who have a higher baseline leptin level. They'll also usually have more problems with obesity. Bananas are the only high amylose fruit. These must also be avoided. Other fruit is okay to eat. For more information about low amylose diets, check our website for sites such as Surviving Mold, Pinterest, The Labyrinth, and other numerous low amylose recipes are available on the web. Appalachian Wellness, where our specialty is you. I'm Raymond Oenbrink, the President and CEO of Appalachian Wellness here in Asheville. We're going to talk about correcting the matrix metalloproteinase 9, MMP, in CIRS. MMP9 is produced by cleavage of MMP14. This is a marker for spread of inflammation through soft tissues. MMP9 helps to basically clear a path for inflammation to spread through tissues in the body. That's its role in the body. It allows these inflammatory mediators to migrate through tissues, spreading inflammation through the extracellular matrix it has broken down. This level will be increased and elevated with uncontrolled CIRS. Lowering MMP9 is accomplished with omega-3 fatty acids such as eicosapentaenoic acid and doxohexaenoic acid, which come mainly from fish, so they're sometimes called marine omega-3s. These should be taken at least 4 grams a day, usually 2 grams twice a day. Alpha-linoleic acid, ALA, is another essential, which means unable to be produced by the human body, omega-3 fatty acid. Omega fatty acids work best when the leptin is less than 7. If leptin is above 7, however, pioglitazone, also known as Actos, is a thiazolidinedione, TZD, anti-diabetes medicine that has a black box warning. This is off-label use of this medication, so patient-informed consent would be advisable, or at least documentation that it was reviewed in the chart about being linked with congestive heart failures. So TZDs have been linked with CHF. Typically, however, this medication will be used for a much shorter duration of time than a diabetic would use it. Whereas a diabetic might use it for years, somebody with CIRS might be on this medication for just weeks to months. And there are some references available for this medication if you're interested. Appalachian Wellness, for a new tomorrow and a new you. I'm Dr. Oenbrink, owner and CEO of Appalachian Wellness here in Asheville. You can follow us on social media. Today we're going to talk about correcting low vascular endothelial growth factor, also known as VEGF. Low VEGF can occur despite the lack of appropriate delivery of oxygen and nutrients at the capillary cellular level. Typically, when this low oxygenation is going on, the VEGF levels will increase, but with CIRS, the mechanism is all screwed up. So this is what happens in CIRS. Blocking VEGF, as I've mentioned before, is also being used as a therapy against cancer. You don't find too many cancer patients with CIRS. VIP supplementation, vasoactive intestinal peptide given by nasal spray, is useful and is generally considered the safest way to correct the low VEGF. Erythropoietin will also resolve the low VEGF if VIP alone is inadequate, but the VIP is a more risky option as does have potential problems as has been reviewed. Appalachian Wellness for a new tomorrow and a new you. I'm Raymond Oenbrink, the owner, CEO of Appalachian Wellness here in Asheville. You can follow us on social media if you like. We're going to talk about the complement system, specifically C3A and C4A, and how they're affected in CIRS. This is part of the immune system that we don't really study very much as a general rule, but it's a key component for understanding what's going on in this disease process. C3A tends to increase in the presence of foreign membranes. Borrelia burgdorferi is the causative agent of Lyme disease and causes a great increase of C3A, which can be used as a marker for the inciting event of a patient's development of CIRS. It's an extracellular pathogen that has the ability to hide intracellularly. It has a very slow doubling time, thus necessitating prolonged treatment with antibiotics. It can be hard sometimes to know when to stop the antibiotics in a patient who is obviously still sick and doesn't appear to be fully recovered from their tick-borne illness. The lack of recognition of this transition from acute infection to chronic inflammation due to a malfunctioning immune system in HLA genetically susceptible patients is an easily understood source of confusion. There are some references that will lead more information on this topic. C4A, on the other hand, is a marker for biotoxins in general, which is much less specific than the C3A bacterial membrane link. C4A levels can even rise in the presence of volatile organic compounds, VOCs, which are present in water-damaged buildings. Erythropoietin can lower C4A and TGF-beta1. It works well in CIRS mycotoxic patients, but it is risky to use. This use will be off-label and should involve documentation of informed consent in the chart. Baseline labs for this would include a TGF-beta1 C4A D-dimer, because it can cause blood clots, like blood clots in the legs and the lungs, which can be lethal, and a blood count. If during treatment the hemoglobin gets to be over 16.5, it's gone too high. The FDA does not want that hemoglobin above 10 grams. It's also a good idea to record the lot number of the erythropoietin product that's being used. Erythropoietin dosed at 8,000 units twice per week for 5 doses or until the hemoglobin is above 10. Beware of the thrombosis complications. Have a very high suspicion for the kind of episode that could be suggestive of a deep vein thrombosis in the leg or a pulmonary embolism in the lung, which can be lethal. Appalachian Wellness for a new tomorrow and a new you. I'm Raymond Oenbrink, President and CEO of Appalachian Wellness here in Asheville. You can follow us on social media. We're going to talk about reducing the elevated transforming growth factor beta-1, TGF-B1, in CIRS. The sequence of steps in this progression reflect the stepwise progression of treatment of this disease. Earlier steps on this pathway will often correct the latter system pathway pathology issues. If the TGF-beta1 remains elevated despite correction of prior issues, other steps are available and can be added as necessary. Transforming growth factor beta-1 elevations are problematic, indicating remodeling, autoimmunity, and transforming cells. If TGF-beta1 downregulates VEGF, lowering the amount of oxygen available in the body for the mitochondria of different tissues, we've got a real problem. TGF-beta1 elevations cause anti-neutrophil cytoplasmic antibodies, ANCA levels, to rise, reflecting cellular immunity and producing adverse effects on the brain, tremors, multiple sclerosis, learning disabilities, the lung, potentially lethal pulmonary hypertension, and the immune system, worsening autoimmunity and dysregulation. TGF-B1 tends to really affect the lung, liver, and skin. So a lot of times you'll see like eczematous fibrotic sort of plaques that form on the skin. That can be an indication also of how somebody is doing with their disease. Losartan, 12.5 to 50 milligrams twice a day. Be careful of orthostasis, syncope, low blood pressure can help lower the elevations of TGF-B1. Losartan is a blood pressure medicine. It's dosed twice a day. And you can get up to 100 milligrams a day, but as with any medication that's being started, it's a good idea to start slow and go slow, start low and go slow as you titrate the medicine up for effect. EXP3179 is an experimental compound. It's actually a metabolite of losartan that has even stronger effects at lowering TGF-B1. It should be noted too, losartan is the only angiotensin receptor blocker, ARB, that has been associated with this effect on TGF-B1. The TGF-B1 is tricky to collect. It needs to be collected properly in a pre-chilled lavender tube. What I do when I'm going to the lab to have it drawn is I bring along a glass of ice water. And when I get there, I tell the tech I'd like a purple tube, and I stick it. When I say purple, that means a purple stopper on it. I put that tube in my glass of ice water. And what happens is the ice water pre-chills the glass tube very rapidly due to the specific heat of water. It sucks the heat out of the glass and the inside of the tube, so it's already ready to go. From there, it's got to be immediately double spun and refrigerated as platelet poor plasma. If it's not collected properly, you will have false elevations of the TGF-B1 on your lab report. Intranasal vasoactive intestinal peptide is also a lifesaver for correcting elevated TGF-B1, and of course erythropoietin can do it as well. Appalachian Wellness, for a new tomorrow and a new you. I'm Raymond Oenbrink, President and CEO of Appalachian Wellness here in Nashville. You can follow us on social media. We're going to talk about replacing low vasoactive intestinal peptide using a nasal spray to correct the abnormalities, the imbalances, and help to restore normal health after an affected CIRS attack. Let's not kill the golden goose by using VIP inappropriately. This is the biggest advance ever in the treatment of CIRS. It has many, many amazing, almost magic properties. The FDA has designated VIP as treatment for pulmonary hypertension only. Now, pulmonary hypertension can occur from CIRS, so if you've got that, unfortunately, it tends to be a one-way terminal illness, but it can actually be reversed with the use of VIP. Even without pulmonary hypertension, though, this drug works amazingly well for CIRS. It downregulates MASP-2, the C4 activator that causes C4A formation. It restores the balance of vitamin D3, downregulates the aromatase enzyme, which breaks down testosterone, among other hormones, raising the testosterone and lowering the estrogens. It upregulates, increases the low levels of VEGF. If lactose, fish oil, omega-3s don't work, VIP will correct the low VEGF. It restores the diminished VO2 max. I can't talk about this one enough, especially with somebody with pulmonary hypertension. They can get short of breath taking a shower. Halfway through the shower, they have to stop and they're panting just to try to catch their breath. I mean, it's a miserable existence. You start these people on VIP, and all of a sudden they can breathe better. And things that used to wear them out and leave them breathless, walking 100 feet down the hallway, all of a sudden they don't think about it anymore. They can just get up and go. It's just a miraculous drug. It reduces the shortness of breath not only on exertion but even at rest. And when you've got shortness of breath at rest, by definition, that's New York Heart Association stage 4 congestive heart failure. That's really a bad prognosis when you've got that. It also has immunoregulatory effects. This is actually a neuroimmune, a brain endocrine, immune system link. It improves thinking problems. It drives up the CD4, CD25, and FOXP3, which helps to turn that off switch back into action again when the immune system is activated. It reduces joint stiffness in about 10 minutes due to endorphin release. Pain just suddenly diminishes immediately. It improves exercise tolerance. It causes a global improvement in all modalities. Typically, within 5 minutes of the first dose, patients can take a deeper breath. Joint symptoms at baseline. They may have tight, clenched hands when they come in, will typically open up and relax when you started on VIP. This immediate pain relief cannot be overstated. It is a huge thing. It's a big deal, and boy, the patients will love you for it, and they'll follow you anywhere. Cognitive issues, unfortunately, don't respond quite as quickly. If there's a sudden increase in TGFB1, there probably has been recent exposure to a new source of toxin causing, cytokine storm, and you've got to go back to square one again. So keep an eye out for that. If this TGFB1 usually goes up real bad all of a sudden, typically also the visual contrast sensitivity effect will plummet, and those are good indicators that you've got a new problem on your hands. VIP 50 micrograms 4 times a day corrects the paradoxical rise in the pulmonary artery systolic pressure that occurs with exercise in days, not weeks, with durable effects with titration over time to twice a day, and over further time it's possible to actually stop the use of the VIP as long as you don't have any re-exposure. If there's re-exposure, again, everything goes back to square one. Warning regarding the VIP. It can cause the lipase to increase a bit, so it's important to measure baseline lipase and then monthly, and also measure some VO2 maxes if you can to see how well they're burning oxygen. Draw blood at baseline, lipase, TGFB1, C4A, and VEGF, and then give the VIP. Repeat to draw the VEGF, C4A, and TGFB1 in 15 minutes. And get a monthly monthly lipase, because again, you've got to watch out for pancreatitis. If you do get pancreatitis from the VIP, it's got to be stopped, which the patient won't be real happy about, but pancreatitis can also be a lethal illness. And don't forget to check that lipase monthly while they're on the VIP. Appalachian Wellness, for a new tomorrow and a new you. I'm Raymond Oenbrink, President and CEO of Appalachian Wellness here in Asheville. You can follow us on social media. This is a review of the VIP trial protocol, or how to give the first dose of VIP, vasoactive intestinal peptide. First, you have to make sure that the patient qualifies with all the material that we've checked before. The TGFB1 has to still be elevated. The MSH and C4, ERMI, and HLA-2 all have to be within the appropriate parameters. When you go to have the TGFB1 drawn, bring a glass of ice water along to pre-chill the tube and make sure the lab tech understands. Lavender tube, double spun, refrigerated immediately. Platelet plasma has to be used. The VIP must be kept refrigerated. Draw the baseline lipase, VEGF, C4A, TGFB1. Give the VIP, repeat that blood work in 15 minutes if tolerated. You don't have to repeat the lipase necessarily, but at least the VEGF, C4A, and TGFB1. Continue 2 puffs nasally of the VIP 4 times a day. Reevaluate monthly, and don't forget to draw that lipase monthly. In 6 months, the dose could be replaced from 4 times a day to twice a day, and then slowly to once a day, providing there is no re-exposure. If there is re-exposure, you're back to square one. You've got to stop. You've got to look all over, find out where is the problem, what happened, how can we get away from it. Use the cholestyramine, use the Welchol, use whatever else is necessary depending on what your doctor tells you have to take, and just be patient. This disease will kill you if you don't do everything exactly right, and it will certainly get your attention by making you suffer. Thank you. Appalachian Wellness, for a new tomorrow and a new you. I'm Raymond Oenbrink, President and CEO of Appalachian Wellness here in Asheville. You can follow us on social media. Relapse and CIRS. You've got to return to square one for any sign of a relapse. You cannot take shortcuts with this disease. It wants to kill you. Remember, CIRS patients, it's a host disease, not a dose response, and that they get sicker quicker. There are no shortcuts in treating CIRS. Absolute, complete avoidance of triggers is mandatory. Although a fully recovered person may be able to tolerate a little bit of time, minutes to even hours, depending on severity, concentration of VOCs and toxins, in a high-risk situation such as a water-damaged building, near a fish kill, or exposure to ciguatoxin, the patient who has been previously exposed has an immune system that has been primed for life. And like an elephant, your immune system's got a great memory thanks to those B cells. They will get sicker quicker. For this reason, they may respond more slowly after their first ever treatment session. They may not recover as quickly to subsequent exposures as they did to their initial exposure. This is the very nature of CIRS. Appalachian Wellness, for a new tomorrow and a new you. Our specialty is you. I'm Raymond Oenbrink, President and CEO of Appalachian Wellness here in Asheville. You can follow us on social media. CIRS, the final check for stability off of medications. After working through the protocol, being able to stop at any time if full symptom resolution occurs, it may be safe to slowly wean off and discontinue all medications with careful monitoring for relapse. If there have been no re-exposures, the patient should do well and be able to tolerate monitored sequential discontinuation of one medication and therapeutic step at a time. At any time the patient condition deteriorates, however, it's necessary to return to square one, the initial start of the CIRS protocol, identification and elimination of the problem, and then start from scratch and proceed ahead slowly.